Good morning. This is the House Appropriations Committee. It is Tuesday, March 10th, 2026. It is 10:50 a.m. and we're just back from a roll call and back to continuing to get an overview of Vermont's rural health transformation program. So back to you, Joe. Thank you for your patience.
Of course. Thank you so much. Okay, I'm gonna actually keep going. Okay, this is my big picture. Oh, darn it, this slide is still wrong. How does that happen?
You had all this time to.
Goodness, oh my gosh. I don't know how it happens. We just keep pulling from the wrong deck, I
You
think.
can ignore something if we're supposed to.
The word housing, you can ignore that. We're not, we were not able to do that one. I cannot believe that is still in there.
Which one are we crossing out?
Sorry, under strength and rural health workforce, we had hoped to do a workforce housing project and I have changed the slide 3 times.
So housing is not right, but training programs.
Yeah, anyway.
Okay.
I apologize. I don't know how I make that mistake over and over again. So this is this is how I like to think about these projects, but since you want me to actually go through the list, I'm not going to spend any time on this slide.
Okay.
This grouping works better in my brain, but for what that's worth. Okay. Ongoing stakeholder engagement. So I mentioned some of this. We have a program page with a public contact form. So if people want to reach out to us or let us know about project ideas, that's the place to do that. And then also on that website is our project narrative, literally what we submitted to CMS, a summary of the projects, maybe a 2-pager, and then this list of projects. And if you've downloaded this list before, we made a minor change to it recently. There was one project that every time I read the words, I couldn't remember what they meant. And so I thought if I didn't understand them, maybe no one else did either. So we just reworded them. Project 17, it's reworded. Okay, a little more sense. And then as I think I mentioned also, we are, in terms of our stakeholder engagement, we have a lot of committees that already exist. We have a strategic plan advisory committee. We have a primary care steering committee. We have lots of work that we've already done on healthcare reform, and we certainly have lots of provider relationships. So we have a lot of ways to gather feedback and information. I think that's my last slide. Yeah. Okay, I'm going to stop sharing. Well, I guess you want me to share the list of projects too. I want to actually say before I jump into the projects, a few more things about just where we are in our process. So I think I mentioned that August 1st is our sort of internal deadline for obligating the funds. And so we've been starting to think about the work in sort of different kinds of buckets as we think about the deadline. So the first projects we want to get out the door are things that are going to require either a competitive bid or where we're going to have multiple subrecipients. So things where we need to put something out and lots of people, lots of organizations are going to apply, because that's going to take the longest to get sorted out, right? When we have lots of different partners, especially if we're choosing between partners. And so we have, in terms of prioritization, and this is actually different, it's not really by initiative, it's really by activity. The things that require more time, we're trying to do first. So this is why I say that when we got this sort of milestone scoring from CMS based on initiative, I started to think, oh boy, we got to make sure we're thinking about this in 2 ways, right? And so we have, I believe the very first RFP was released this week, and it's going to be going up on our website if it hasn't already, on the RHT website. So different departments are releasing notices of funding opportunities through their usual channels. And then we're also cross-posting on the Rural Health Transformation site. And then we have a listserv that we built that people can actually sign up for on our website, and so that they get an announcement. So we'll probably do like a weekly announcement saying like, hey, these grant opportunities have been posted, so that our provider community doesn't have to like refresh the website, every day to make sure that they haven't missed something. So that's sort of one, we're thinking about it. So we're working on those projects first. And it's not completely sequential. There is parallel work going on. But we're also working on, then we think about the projects where we have one obvious partner. So some of our workforce projects, like we might have one obvious partner, like VSAC. And so if there's one obvious partner, then there's a little more time to work with that obvious partner to get things set up because we don't have the back and forth of a competitive process or a multiple awardee process. And then we also have some things that are actually payment models. And so those are dollars that are going straight from us to providers. And so we're working on those also kind of separately because they're not, again, they don't have the same, it's just a different way it's just a different, we're operationalizing those differently.
Wait, you had a question?
So that's how I'm thinking about the work.
That strategy, I think that strategy also gets the most money obligated as fast as possible.
I think so, because we're trying to do give the most time for the hardest stuff to obligate. Yeah,
I'm thinking, looking at it through the lens of, how do we get the money out the door?
yes,
Or it's through the other lens.
yes, yeah, that we felt like some of these awards really are gonna require more, just are more complicated to get finalized, so we want to do the hard stuff as fast as we could, yep. But there's still plenty of work to do. So, okay, I am going to see, I think I shared my screen and I yeah, okay. All right. This is impossible to read on the screen. It is not impossible to read if you print it or if you go to our website.
Copies.
You all have copies. I actually think I'm gonna work from the copy. Maybe I'll just not share my screen because it's not helpful to anyone in the
Anybody
room.
who's watching.
Oh, yeah, okay.
Might like it. so-
Yeah, okay, I'll leave it at that.
Yeah, so don't worry about the size. They can deal with it when they're watching.
Okay, yeah, okay,
If people want to see it and get their own paper copy, it's on your website and they.
on our website.
And it will be posted if it hasn't already, it's on our committee page also. Yeah, so lots of places people can find it.
Great, okay. So the first 7 projects all fall under the regionalization initiative. And so regionalization is really thinking about how we provide care in the various regions of Vermont, and some care we want to make sure we have in all regions, right? There's some care that you need really close to home, like primary care you want really close to home. Some care can be provided in regions, and then there's some care that we would probably expect to only provide on a statewide basis. So like tertiary, like complex hospital care. So these are initiatives that are related to what we think of as regionalization, services in various regions of Vermont. So one is, and I'm not going to go deep into any of them, or we are going to be here all morning. I've done the whole thing a couple times, and it does take a while if I go deep. So I'm going to stay high, and if you want me to go deeper on one, I will, but I'm going to.
Right, we'll try to keep ourselves at a high level.
Okay, so and again, this is why I say that measuring these all together is going to be a little hard, and we're going to need to think it through. So we've got community paramedicine or mobile integrated health. So that's using our EMS workforce in a new way. There's a pilot happening now in the Brattleboro region where essentially EMS is providing care in people's homes. That the EMS workforce, and this is how I think about it, is a workforce that actually sometimes has capacity in a way that a lot of the rest of the healthcare system, that they have no time, nobody else has time on any time that they're not already engaged in clinical care. And so using our EMS workforce in a new way is a strategy to bringing more care closer to home. What we don't want to do is, we do have, of course, home health. And so we got to make sure we don't have an interplay there, or we want to sort that through. I used to work for home health. That's important to me. But I think there's plenty of opportunity for care at home. So that's going to be a pretty significant project once it gets fully underway, but quite a bit of work to do because there's policy work as well as just, it's not entirely straightforward on the policy side. There's some legal framework work to do. Facility upgrades, we've now actually moved this is a change from how we originally applied, but there's also a facility cap. So there's both the rules about facility upgrades, meaning minor renovations only. And then there's also a cap. The cap is pretty high. I actually can't think of it now, but I think it's higher than the provider payment cap.
Okay, and that was
30 million-ish, but we probably not gonna be able to spend it all just given the restrictions. We used to have facility upgrades in multiple projects. We had them in different projects, and we realized with the cap, that was gonna get really confusing, and so we changed it with CMS and we put them all in this bucket. We didn't change the dollars of any of the projects, we just changed the words so that for some projects, you're gonna see me talk about projects that have a facility implication. Some projects are gonna require 2 grant applications, one for the main project and one for any facility upgrades. So we're gonna have to keep them separate. So that's gonna be a whole range of stuff. Urgent mental health and substance abuse, urgent care expansion. I'm gonna skip number 4 for a second. Mobile units for integrated mental health and substance use treatment, and mobile units for dental care. Number 4 is transformation, integration, and regionalization support grants. That is a sort of broader bucket. These dollars have not been approved by CMS for release. We need to give them more details about how we're going to do this. But the idea is that we wanted to leave room for our provider partners in particular to think about ways in which they might do transformative work to change our system, to move care out of hospitals into the community that we couldn't think of in the small amount of time we had in which to apply for this grant. So we kind of left this open on purpose, but we are going to have to nail it down in order for CMS to release the dollars. They have not released these dollars yet. We're not authorized to do an RFP. Oh, sorry. Thank you. So that is, there's one more regionalization, number 7, high acuity services in nursing homes. So dialysis and ventilators in nursing homes.
That's equipment related.
Yeah.
Okay, Lynn?
Specifically on, maybe generally as well, facility upgrades, and maybe even a number 7. How does this all work with CON, with our existing regulatory framework for approvals?
Nothing changes there.
They don't have a conflict between.
No, I mean, if it's something that would require a CON, it will require a CON. Yeah.
Thank you.
Yeah. Okay, so that's regionalization. And then there's a series of shared services. So the big idea behind shared services is essentially like back-end operations to allow organizations to share administrative and other kinds of things together, which hopefully to reduce costs and complexity. So we have a number of those that are already planned, and actually we've heard some ideas from other provider types that we hadn't contemplated that we are also thinking through. So that is, there is some interest from some hospitals in having a shared human resources information system and also a shared electronic medical record. So that a shared electronic medical record will essentially sort of more quickly improve interoperability and allow for more information to go between hospitals around patients who might move from one hospital to another. It doesn't negate the work we need to do to make sure that all of our provider types can communicate, because we also want hospitals to have information from home health and vice versa. So we still need health information, but that's a strategy to kind of get us a little further, a little faster. There are some limits on how much we can fund hospital EMRs based on there's previous federal funding to help with EHRs, and so there's a limit if a hospital received that funding. Every one of these activities, like you open it up and it's just like lots of little pieces that you gotta untangle.
Okay, yeah.
Yeah, so we also want to have a statewide e-consult. So this is really a platform. This one I think needs some more, we're doing some more thought on this, because this is both a platform, a tool for the work, but also, thank you, but also the sort of like, how do the conversations happen? But the idea is to bring expert consultation that we might only have available in parts of our state to rural communities. And help the physicians in those rural communities to have access to expert advice, specialist advice. Grants to providers for remote patient monitoring. So remote patient monitoring is as equipment in the home. Home health agencies and some primary care use this. That it just looks for sort of key data, blood pressure, weight, various indicators of exacerbations of chronic diseases. And sometimes what we find is that if you are tracking those things, you can sometimes prevent a hospitalization or an emergency room visit if you're able to sort of watch the changes. This is really especially useful with people who have multiple chronic conditions who are living at home. So that's dollars for those providers for that. Grants this is really for rural independent practices to adopt telehealth technology. That's another piece. Grants to providers for AI transcription, which some providers are finding really, really helpful, but it does cost money. So this would just bring it to more practices. That's our shared services bucket. Then we have a primary care bucket. I would say this whole thing is mostly about modernizing the blueprint. So it's about supporting primary care and modernizing the blueprint. What that means is we call them capacity payments to primary care practices to have things like longer hours, care coordinators. So to have additional services in primary care. It also will support mental health integration into primary care teams. It will support our community health teams, which is a long-standing blueprint strategy where we have teams of other types of nutrition and other kinds of services to wrap around mental health. But it's essentially all the way through 18 is modernizing the blueprint. Actually 20 also. 19 is particular to supporting an expansion of an FQHC, and we had an idea for this is coming out of a particular project that seems to is not on the same course that it was on, but the idea was to add new FQHC capacity in a part of the state that doesn't have it right now. Back 20 goes back to primary care blueprint. So this is that PMPM payment. So on some of these, like 20 and 21, this is where that provider payment cap, these are dollars that haven't been released by CMS. These are payment models, and
Are you on 20 still?
I'm on 20 and 21.
Okay.
Yeah, so those two, incentivizing access to primary care, and then specialty and primary care performance payments, which is essentially incentive payments to help primary and specialty care work together. Or it goes with the e-consult to help support incentivize the consultation. So this is all going to be dollars that come from AHS to providers. Some of them are going to be defined as provider payments potentially, so they're going to be subject to the cap. So these dollars have not been released by CMS yet. There's more work to do on those.
So on all of these particular projects.
20 and 21 and
21, you're still waiting to get. Wayne, did you have a question?
Yeah, so it's incentivized consultation. So how are you going to incentivize it? What's mechanism for you to do?
It's really, people need to be paid for their time essentially. So figuring out a way to create that incentive. So like I said, more work to be done to develop how that model is exactly going to work. Okay, and then now I'm on 22, recovery housing for individuals with substance use disorder. So we have recovery housing in Vermont already. This won't pay for what we already have, but it will pay for us to expand. I think this is the first RFP that's out, actually.
So, have you already sent out notice of funding opportunity?
I think this one just went out, and I think this is the one that just went out.
Okay.
And then we get to workforce. So the housing program number 23 is no longer on the table. We should probably just update that.
Just cross that off.
Just cross it off. Yep. Yep. Yeah. And then we have various other work.
Dave has a question.
Oh, sorry.
Just a quick question. The recovery housing, you mentioned earlier that you're limited in terms of buildings and such.
But we can
Is there an
lease.
exemption on the recovery housing?
No, it's often, those buildings are often leased.
Okay,
And so, yeah, so we
those are
have,
permitted.
yeah.
Thank
At
you.
least it doesn't increase the grand list, it's just a business transaction. Right, okay.
And then there's also operation, we can't necessarily fund the clinician salaries, but there's also operational salaries that we can fund, especially to get them off the ground. Yep. I just want to be clear, I'm not a subject matter expert on every single project, so we do have, I mean, that's being run by the health department, that.
Thank you.
project. Yeah. So a whole bunch of workforce, so LNA training, tuition assistance, critical occupation tuition program, Maple Mountain Family Medicine residency. So that's essentially a rural primary care residency for physicians. Pharmacy test to treat. You're actually going to see this later, I think today. We need a little bit of additional scope of practice room. And so there's actually an amendment to an OPR bill that I think you're going to see later today. I think.
Which one is that?
That's the 28 pharmacy test to treat. So that the idea there is to allow pharmacists to test for, say, strep and provide treatment on site instead of people having to go to the doctor and then the pharmacy.
Oh, yes, test to treat.
Yeah.
Oh, did you skip over all those other ones in workforce?
I went through, I just said them really fast.
So
I can pause, I can go back.
I just wanted to point out, I'm glad to see about the Maple Mountain
Yes.
Consortium.
Yes. That was the only named subrecipient in our grant. So we could have named more. You were allowed to name subrecipients in the actual application to CMS. That was the only one that was so baked that we felt like we could do that. Yep.
Wayne, that was actually the autumn to quiet people down outside.
Thank you.
Now is probably not the time, but we need to know eventually more about the tuition and what could be done because
We'll talk about that.
we have other places.
Well, we'll talk about that. Yeah. These are some different programs.
Yeah, yes. Conditional financial assistance, that's essentially tuition assistance with a 5-year residency requirement. So that's different than anything we have right now.
Right.
Yeah.
Which I like that idea of people committing
Yes.
5 years in Vermont.
Yes, and if they don't commit, then the tuition assistance becomes debt. And then healthcare professions residency. And so this one is really to help new students. So it's not tuition assistance, it's helping new grads transition into the workforce. And so, for example, a home health example, it used to be that home health agencies would say that you don't ever hire a new nurse into home health because home health requires high degree of experience. You're alone down a long dirt road, knocking on a strange door. And so then you're by yourself in the care setting. So you really need to be an experienced nurse. And home health used to really not hire new nurses into home health. Now they're trying to build these residency programs because we have such a workforce shortage in Vermont and other places and what no one pays for is for a new nurse to go into the field, say, with an experienced nurse. There's no payment for that. We only pay for the service. Service gets paid for one time. It doesn't pay for 2 people to provide care or to train. And so the idea of this is to create these residencies, preceptors, to help just bring along a new workforce into various settings and help them transition and hopefully help retain them in healthcare. Okay, that's that one. And then, so those were all, I just will say this, those were all things that are going to go out that are going to become subrecipient grants, following the rules that we follow around grants. There are also going to be some consultants and contractors, and these are going to follow our procurement rules. And so we have a statewide healthcare delivery strategic plan, and we would like to use some of these dollars to actually hire some help to get that developed. We have the statewide assessment to improve health coverage affordability. There's really a couple of particular things on the table, like reinsurance for the healthcare exchange that we can pay for with these dollars, we think. And contractors, we have to have an independent evaluator for the entire project. Transformation, analytics and support. So this is analytics to hospitals and non-hospital providers to help support transformation. So that means like help giving them assistance to think through how they might change what services they provide and how they provide them. So for example, if a hospital is thinking about giving up a service, which can happen, or sharing a service, the hospital gives up a service, one question that we immediately ask ourselves is there anybody else who's going to be able to take that service on in the region? So even if there's another hospital that provides that service, they might not have any capacity. And so there's various analytics work, and also to really look at efficiency and whether care can be delivered more efficiently. That's actually probably where I think we're going to see some actual savings. Interfacility transfers. I would say this one is something where we understand the problem better than we understand the solution. And I think this one might take us longer to get through. But what we do know is that we don't always have good information about where beds are available, which takes providers a lot of time as they need to try to move people through the system. Statewide closed loop referrals. And, I know this is a shared services, but it's because it's a contract, it's in a different bucket. It's in a different part of the document. And then,
has that been approved to do yet, or is that?
that one is, yes, that one is released. Yep.
Okay,
Yeah, we're going to need to make a new numbering system because the grants are numbered 1 through whatever. And then the contracts are also numbered 1 through whatever. And so you can't just say project number, blah, 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 because they're.
you just need a bigger spreadsheet with a line that says no faux release.
Yeah, so they.
Sector select.
Yeah, I do have a spreadsheet. So I have other spreadsheets. Yes, this is my project.
This is the first one.
I do have, yes, we have one that is like this, but keeps going.
Yes.
Yeah. And then this is number 5 is it's essentially a tool that the Green Mountain Care Board asked us to apply for. Yeah, which we did. That's
Okay, and that's on the accepted list.
yes. Yeah, and that one's just going to be an MOU between us and the Green Mountain Care Board. I mean, there's other, rules obviously to follow, like procurement and,
Yeah.
ADS will, if it's a Vermont system that it implicates that too, but.
Good data, so we like good data. So this is really helpful. Thank you.
Welcome.
I know you are, one of the things you're doing is going to be hiring a project manager to help you with this.
Yes. Yes.
Where does that stand right now? Are you?
We're close.
Okay, so you started the process and you're hopefully close to making an offer, is what you're saying. You gotta be.
We're even closer than that, but yeah,
Okay.
yeah, but I don't want to say anything.
No,
Yeah.
no, but I'm glad to know that
Yes,
you're close.
yes. And then we had 2 positions that were approved early on that we
Okay.
moved through the process quickly. The project manager and then a finance person for the business office. So essentially the lead programmatic person and the lead business office person. Those 2 positions we put through the process earlier, and then the other positions, including a deputy and some various project leader positions, those are making their way through the process now. So those haven't been posted yet, but those 2 positions are, I think actually I believe the finance manager has been filled.
Great. Dave, question?
Yeah, this probably will sound naive, but given all the demands you have, do you think it's conceivable that after those October deadlines, if across the nation, likely there's going to be money put back into the table because people just couldn't make it happen, that as you're working through these projects, you might say, gee, number 17 or whatever number, we learned a lot, that's not going to work. We understand that money will go back, but could you still be in a position where you might be able to apply for some of those unused funds for things that you learned while you were doing this and thereby increase your percentage 15% on provider reimbursement? Or is that just got so much going on in year 1, not likely to happen?
I think it's hard to predict what our year 2 award will look like. So whether it'll be more or less than $195 million, we know it'll be 100. We can be pretty certain of that, but we don't really know beyond that. I do think that we are going to move back into a creative space about thinking about year 2 and 3. We're not in a creative space right now. We're in like do what we already promised. That's gonna be enough as it is. But yes, it
Evolve.
is going to evolve. I expect it to
Seize that
evolve.
opportunity.
Yes, yes, I definitely expect it to evolve and, yeah. Yeah, and our thinking is already evolving. We're already looking at certain projects where we think we might, we think it might take longer, so we may not be able to spend all the dollars we dedicated to it in the first year. But we might want to say, okay, in the second year, actually, that's the amount we'll spend. And in the first year, maybe we'll dedicate those dollars to a project that has room to spend more dollars,
Right, okay, so.
where it's easier to spend it. you know,
Right, so
there's
it's
certain-
still your intent to spend all the money, it just may not be all of it in the budget.
They move things
as
around.
I thought.
We are trying to spend it all.
You have the ability to move some of that money around within the projects that have been approved.
Yeah, this is where the cooperative agreement comes into play, that we do have that flexibility. That's the good part of the cooperative
Yes,
agreement. So
okay.
high degree of oversight, but also that ability to make some of those kinds of adjustments with CMS approval, of course.
Right.
There is opportunity to make adjustments with
Right.
our budget. I mean, when I've talked to our business office, we have thought that as this gets going, we might be submitting new budgets to CMS as often as every week.
For specific projects.
For overall, because it will make enough changes that we'll need to say, this project has changed in this way, these words have changed in this way, yeah.
It's building a house and you have a general contractor and the person gets in and they realize they want the light switch over here instead of over there, and they need 3 more in the bedroom than they thought, and that's kind of what you're.
Does feel like that a little
Yeah.
bit, yeah, because we could only predict, well, we had so many unknowns.
Yeah,
And so as more unknowns come into focus, it is changing how we're thinking about it, right? I mean, we didn't know how much the award was gonna be. We knew it would be $100 million. We didn't know how close we could get to 200.
right.
So there was a lot we didn't know during the application process, and as it comes into focus for all the states and for CMS, we expect changes.
Well, I'm glad you can work with them to have some flexibility around that. That's good. Lindsay?
Tolerance for ambiguity is an important skill and.
Yes, flexibility is key with all of this.
Yeah.
But, yeah, Lynn. I looked at Lynn because I asked her if she had a question and then you raised your hand. So go ahead.
I understand where you're coming from.
More coffee.
Yeah, I am assuming that since the goals transformation, that we're really looking at sustainable
Yes,
changes.
Yes.
That are supportable through our regular budget.
that is exactly how we're thinking about it, or supportable, say, if we get the ahead model. So I think I talked about this with some of those payment models. They were, like, we did have a Medicare component funded by Medicare for Blueprint. Right now we're funding that. This year we have one-time state dollars that we're using for it. The RHT has dollars for that could be in the second year. The idea, though, the sustainability plan is if we go say to the ahead model or some other federal agreement where we would get Medicare back at the table. Right now, Medicare is essentially not at the table on healthcare reform with us because we're between models. Yep. So some things might continue, but with different supports. Yep. But yes, we're thinking about it, I think, as you are, in terms of really thinking about being careful about what we add to the base.
Lynn.
Yeah, this is really interesting.
It really is. I have not been bored since September 15th.
No, I mean,
Yeah.
transformation
Yes.
is necessary,
Yes, it really is.
having gone through 5 years of transformation of the state colleges.
Right.
Yes.
And looking at what we're trying to do with the K-12.
Yes. Yep.
And seeing the problems with our healthcare, having been involved in
Yeah.
other issues.
It's hard.
I mean, I think this is good.
Yes, it is good. And it's also hard. It's both. And we do have a really great transformation team. A transformation leader along with our Blueprint team is sort of our transformation lead sort of group in the agency. And they're working really closely with hospitals, in particular, thinking about how they might transform the services that they provide. And it does get really layered really fast because there's some services we really need and want that don't necessarily meet the financial needs of the hospitals. And yet there's other services. Anyway, it's complicated.
Yeah,
Yeah.
the thing that I see, this is just came into my head, is that this is, they've used this phrase in the tech industry, I'm not sure exactly how it starts, but it's like, start off and fail fast, and then
Yeah.
learn.
Yes,
I mean, that's what they do. That's their business model.
yes,
And this is more of that than it is like what we did with, I'll say the ACO, where we put a lot of money in, we did a lot of things, and then it essentially failed. And we had to regroup after 5, 10 years or whatever it was.
Well, this is definitely, I think the projects are, the activities are somewhat more discreet. I think, and a little more, like, I think many people can read this and many of these things make sort of have like a face value sense that they make. Yeah.
And the other thing I'm going to ask you, do you see any danger of execution or risk when you start to go into hospitals or into provider situations or any, we've talked about all kinds of things here,
Yeah.
insurance. I mean, there is a lack of willingness to change. How is that gonna be addressed? Or have you even thought it's gonna be a problem?
Yeah. Oh, no. I mean, I think that, yeah, this is sort of getting beyond the scope of rural health transformation itself. And so we have broader healthcare reform goals to transform our system, right? We're using this as a tool to support that. So just to be clear, this isn't our healthcare reform plan. This is a tool that helps support our reform plan. Our transformation team is working really closely with hospitals, with analytics, with technical assistance to really try to think through what makes sense in what needs to be delivered locally, where can we have centers of excellence, what can be delivered regionally. There absolutely are risks. I mean, we are now, I remember when we were trying to move care out of nursing homes and into the community, which we did really successfully, and we are now definitely short nursing home beds, right? We don't have enough nursing home beds now. And once you close capacity, you have to be careful about thinking about capacity and what we keep open and what we close, because it is hard to build it back. And so you do need to really think it through. And yet I think there are real opportunities that hospitals are talking about and looking at for sharing specialists. I mean, sometimes that's just like, they have to, because the oncologist retires and you can't recruit another one into the community. And so you have to think about a different way to make sure people are getting served. So we're always thinking about cost and affordability, that's critical, but also access, because that matters too. And then of course, quality. So it's trying to keep all of those things in the mix. Yeah, absolutely.
Well, Jill, I want to thank you so much.
Yeah, sure.
And,
Okay.
if people have questions, and this is high level, so if we have more details, we can grab Jill offline and ask her questions to clarify any other things. But it's just helpful to see this in the picture of all of what we're doing in AHS and state government and the budget and everything else. So that's been great. So appreciate it.
Yes.
As you continue, I hope you
Thank
get the
you.
project manager on board really soon.
Me too.
Yeah. So
Yeah.
we'll keep our fingers crossed for that. Committee, we are going to meet at 1. We have a bill, a different bill, 67. This was here for a little while last year and we sent it back to government ops and it's back. It's government accountability. We weren't able to get some of the other ones in, but then we'll have a committee discussion about the budget. And I kind of have a concept of a plan for how we're going to do our priorities this year. A little bit different than we did last year, but we'll talk about that this afternoon. So you have a nice rest of your